Evidence also comes from meta-analysis, systematic reviews, and more often than not, from case series, reports, and expert opinion where you can't conduct RCTs. Now, when you look at the barriers to the implementation of such evidence with your practice, the most important thing is the crux of evidence that comes from RCTs are actually from well-designed trials with very careful inclusion and exclusion criteria. And more often than not, the patient that you actually see in your routine practice falls in the exclusion criteria. The evidence is silent on what to do with such kind of patients. Then the other factor is, can you universally extrapolate data? For example, research that is carried out on the Western population, is it applicable to the Asian and the Indian population? We don't know that. What history tells us is that the data of the Western population cannot be blindly applied to those on Indian patients. What about research fraud? We all know Joachim Bolt, we know Stephen Cohen, and so on and so forth. And the problem is that when you have research fraud, they not only contaminate the particular research, they also contaminate most of the meta-analysis and systematic reviews stemming from that particular research. What about poorly designed trials? When you have poorly designed trial, that further adds to the conflicting nature of the evidence that you have at your hand. And more importantly, no one has actually seen what happens when you apply these evidence-based medicines in the outcome of such patients. You can't do such a research for the simple reason that it's not ethical. You can't be seen as applying evidence-based research on one end of the trial and non-evidence-based practice on the other hand of the trial. So you can't actually research these outcomes. The other problems with such evidence is you have almost 62% of such evidence which is based on uncertain relevance. Now, if you remember, there was a trial in 2001 by Vandenberg, and it was the intensive insulin trial, intensive insulin treatment trial, which told you that if you kept the blood sugars in between 81 and 108 milligram percentage in patients who were critically ill, they have a wonderful outcome. And suddenly the world was gung-ho with this one paper, it changed the practice. Suddenly everybody was all about intensive insulin treatment. But what happened was, funnily enough, nobody could ever replicate these results. No one. And it was debunked in 2009 when it was shown that there was higher incidence of hypoglycemia, strokes, and all-cause mortalities because of this tight sugar control. And subsequently in 2009, the concept came up that you need to have liberal sugar targets rather than tight sugar targets. Okay? But for nearly a decade, that drove the practice. You'll be surprised to know that the American College of Cardiology, which is pretty much a very haloed organization when it comes to giving recommendations, bases only 11% of its recommendations on high-level evidence. Majority of it is actually based on low-level evidence or expert opinion where there's no evidence. Well, observation has never been such a bad thing. Most of us see but don't look. The plaster casts were never born out of any randomized controlled trials, simply for the reason you can't be having expectant management of a fracture in one arm and a plaster cast in another. So this was born out of observation, and we know it works. The other barriers are the evidence-based medicine is pretty bureaucratic. It assumes that clinicians are up to date with the current best research and offer them to their patients. And it's also technically complex. You have multiple levels of evidence. You have multiple grades of recommendations. They're pretty much dogmatic, and they're voluminous. By the time you go on to the last page of the guidelines, you pretty much forget what the first page was all about. And there are, to add confusion to the issue, there are multiple guidelines on the same topic. There are multiple guidelines on heart failure, there are multiple guidelines on hypertension. So which guideline do I follow? Do I follow the European guideline? Do I follow the American guideline? Do I follow the Chinese guideline? Because we don't have Indian guidelines for such things. And then all these guidelines address a particular issue. They are very disease specific. They don't take the patient as a whole. So if it's hypertension, the guidelines are all about hypertension. So just like the tram which can travel along defined tracks, so also if you're just dogmatically practicing evidence-based medicine, that's what you're going to do. You're going to end up with just going along defined tracks. oops, what happened here? I was practicing evidence-based medicine. But more often than not, this is the real picture. You have evidence, but your patient is on the opposite side of the evidence, and more often not, there is a conflict of interest in your practice. And this represents your actual practice. It's chaotic, it's not defined, and there are no defined tracks along which you can safely travel. There are other barriers. The most important barrier that most of us suffer at some point of time in our careers is the institutional practice. So what's the institutional practice? You're a young guy, you come in with a lot of evidence, and you join a new center, and they tell you, we do it like it this year, or more importantly, that's not how we do it here, and you better stick to that. Yeah? So your evidence goes out of the window, especially if you are dealing with very senior people in the organization and you have a career ascendancy program or plan. The other thing is resource and expertise. We know the transesophageal echocardiography makes a difference in the surgical outcome of patients who are undergoing cardiac surgery. Maybe 5% of cases or 10% of cases get changed because of the use of a transesophageal echocardiography probe. But what happens if you don't have a team machine, if you don't have expertise, if you don't have people who know how to do the echo? Cultural influences, these also play a role in influencing the decision about patient care, and complexities of decision. The more complex the decision, the more difficult it is to apply evidence, because practicing evidence-based medicine is not a guarantee that you're going to not end up with a medical malpractice suit. So therefore, you have your research evidence, but that's mostly outside the clinical circumstances that you get to deal on a daily basis. And then you take into account, if you take into account the patient's preferences as well as the patient's consent, then you have a very narrow path along which you base your actual practice. Now, the Times magazine in 2001 called it the most influential idea of that year. Patients most influential. Space your practice. Now, the magazine in 2001 called it the most influential idea of the very path space your practice. Now, the magazine in 2000 called it the most influential idea of patients have a very space your practice. Now, the magazine in 2000 called it the most influential idea of a very path space your practice. Now, the magazine in 2000 called it the most influential idea of patients have a very space your practice. Now, the magazine in 2000 called it the most influential idea of a very space your. Now, the called it the patients idea of a very space your practice. Now, the scene into the idea of patients have a very space your practice. Now, the scene into the idea of patients have a very space your practice. Now, the scene into the idea of patients have a very path space your practice. Now, the magazine in 2000 called it the most influential idea of patients have a very space your practice. Now, the magazine in 2000 called it the most influential idea of a very path space your practice. Now, the magazine in 2000 called it the most influential idea of patients have a very space your practice. Now, the magazine in 2000 called it the most influential idea of a very path space your practice. Now, the magazine in 2000 called it the most influential idea of that year. Patients can most influential that year. Most influential that year. Most influential that year. Now, the most influential that year. Most influential called it the most that year. Patients consent. The very path. Space your consent. Now, the magazine in 2000 called it the most influential idea of consent. Patients can research a very, but that's the very research of but that's space your research of but that's now the research of but that's research of called it the most, but that's patients can base the very is path space your business is base. Now, the magazine in 2000 is called it the most influential idea of base patients can in pace your in now the into the inpatient in the very path face your another into the called it the more idea of patients the very another into the called it the more patients for evidence the very path for evidence face your for evidence another for evidence into the for evidence called it the most for evidential idea of for evidence patients for evidence the very fun and use the very fun and use fun and use fun and use fun and use another fun and use another fun and use into the fun and use called it the most fun and use patients fun and use the very path surface your another into the called it the most subtle idea of patients the very another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your another into the called it the most patients the very path face your another into the called it the most idea of patients the very pass your Another magazine into the called at the patient's cut. The very path face your practice. Another magazine into the called at the actual idea of patient's cut. The very pass your practice. Another magazine into the called at the patient's cut. The very path face your practice. Another magazine into the called at the actual idea of patient's cut. The very pass your practice. Another magazine into the called at the patient's cut. The very path face your practice. Another magazine into the called at the actual idea of patient's cut. The very pass your practice. Another magazine into the called at the patient's cut. The very path face your practice. Another magazine into the called at the actual idea of patient's cut. The very pass your practice. Another magazine into the called at the patient's cut. The very face your practice. Another magazine into the called at the patient's cut. The very path face your practice. Another scene into called at the patient's cut. The very face your path practice. Another scene into the idea called at the patient's cut. The very face your practice. Another scene into called at the patient's cut. The very path face your practice. Another scene into the called at the actual idea of patient's cut. The very pass your practice. Another scene into the called at the patient's cut. The very path face your practice. Another scene into the called at the actual idea of patient's cut. The very pass your practice. Another scene into the called at the patient's cut. The very path face your practice. Another scene into the called at the actual idea of patient's cut. The very pass your practice. Another scene into the called at the patient's cut. The very path face your practice. Another scene into the called at the actual idea of patient's cut. The very pass your practice. Another scene into the called at the patient's cut. The very path face your practice. Another scene into the called at the actual idea of patient's cut. The very pass your practice. Another scene into the called at the patient's cut. The very